Y'all are so dirty. So gross. So gross. If she likes it, I love it. If she likes it, I love it. I like that.
He looks so creepy.
And she posted that online?
Yes. That's her husband.
Yeah.
Yes, that's baby daddy. First, look at this picture. Look at this picture. It's from the gender reveal.
What's that other one?
Yeah,
It doesn't have to be.
you gotta rewatch. Sorry, no.
It does come in that.
That's her. Yeah.
So I did. So that's
My birthday today. Yeah. Oh, today's birthday.
No, I thought I printed enough for everyone. Okay. Okay, guys, chapter 10. This is it's our last, like, mom chapter. No, it's a short one. But it's the last mom chapter. We're talking about mom stuff, and then it's newborn and then peds. So this is gonna cover, complications that can occur after birth. So short chapter, we might get through a good portion of it tonight. If not, we'll finish it next week. Okay, so some of the things, you know, people have babies every day. Thousands of babies are born every day. It's often very uncomplicated and benign. Some complications can occur that can affect baby's life, that can affect mom's life. Those are usually related to shock, hemorrhage, thromboembolic disorders or clots, puerperal infections, which are postpartum infections, subinvolution of the uterus, and mood disorders. Shock's going to be the first one that we talk about. Shock is a condition in which the cardiovascular system fails to provide essential oxygen and nutrients to the cells. So postpartum, that can be related to cardiogenic shock, septic shock, hypovolemic shock, and anaphylactic shock. And the focus for this chapter is going to be hypovolemic shock. It is dangerous because body compensation can mask the signs until the condition becomes life-threatening. So your body can kind of adjust and compensate for the blood that's being lost or the infection that's occurring until all of a sudden it's too late. So just to review, postpartum hemorrhage is blood loss greater than 500 mLs for a vaginal delivery and over 1,000 mLs for a C-section. Most cases occur immediately after birth. Sometimes it can be delayed for up to several weeks postpartum. So when we're talking about a postpartum hemorrhage, an early postpartum hemorrhage occurs within the first 24 hours of the baby being born. Okay. A late postpartum hemorrhage occurs anywhere from that after the 24 hours up to 6 weeks. Major risk is hypovolemic shock. Okay. When you have a hemorrhage, you lose blood volume and you are hypovolemic. End up with hypovolemic shock, which interrupts blood flow to body cells and prevents normal oxygenation, nutrient delivery, and waste removal. Signs and symptoms, tachycardia first, right? That's going to be our first maternal sign, tachycardia. Falling systolic blood pressure, pale, cold, clammy skin, mental status changes, and decreased urine output. Hypovolemic shock occurs when the volume of blood is depleted and cannot flow to the circulatory system. This can lead to death if you don't fix it. initially will have increased heart rate and respiratory rates. And the purpose of this is to increase the oxygen content of the red blood cells and also to speed up circulation of what's left in the body so that we can perfuse all of our organs. Okay, blood pressure will show a narrow pulse pressure, so a falling systolic and a rising diastolic. So your two numbers are getting closer and closer together. So instead of having something like, 120 over 80, may see 100 over 90 or 110 over 95, those numbers get very close together. Okay. If you don't fix it, blood flow to organs will eventually stop. Okay, basically the kidneys first, right? So that's why urine output is important. Skin and mucous membranes become pale, cold, and clammy. So management, stop the blood loss. Figure out where it's coming from and stop it. IV fluids can help maintain circulation and replace the fluid that's being lost. Potentially a blood transfusion, depending on how much blood volume is lost, and that's a case-by-case situation. Oxygen can't hurt, right? Puts more oxygen in what's the red blood cells that are left. And a Foley catheter is going to tell us urine output, which is important. It'll tell us if the kidneys are working, or if we've lost so much blood that we're now not perfusing organs. Okay, nursing care, frequent vital signs, monitor oxygen levels, evaluate lochia or postpartum bleeding. Look for hematoma that may be present. We'll talk about those in a minute. Pads are weighed if we're concerned about blood loss. 1 gram equals 1 ml. Evaluate the fundus. The fundus will tell us if it's a problem that's coming from within the uterus or someplace else. After eyes and nose, monitor for anemia and provide emotional support. Okay, I thought I missed a slide. So anemia occurs due to the loss of the erythrocytes, the loss of the red blood cells. Moms may complain of feeling dizzy, lightheaded. They may feel a little nauseous. And again, they'll have increased heart rate and respiratory rate. Moms who have chronic anemia, either going into delivery or following delivery, will be advised to continue iron supplements for the foreseeable future. They may be on them for the rest of their life.
After a postpartum hemorrhage?
After a hemorrhage, or if they have just chronic anemia. Some people just run low and have to be on iron for the rest of their life. Okay, so early postpartum hemorrhage occurs within 24 hours. It will be related to one of 3 things. Either uterine atony, which we'll talk about all 3 of these. Uterine atony, a laceration somewhere, or a hematoma. Okay, so we'll talk about uterine atony first. Uterine atony means that the uterus is boggy or soft. It's not nice and contracted like it's supposed to be. Okay. And if it's not nice and contracted, then all of those vessels where the placenta was attached are going to be bleeding freely. And it's going to increase blood loss. Causes can be related to uterine overdistension, a uterus that was kind of stretched to the max with a big baby or more than one baby, or a long labor, something that tires out the muscle. It can be related to retained placental fragments, or the use of drugs during labor that relax the uterus, like our tocolytics. Okay, so we'll have lots of lochia that may have large clots. So when you're palpating for the fundus, it's gonna be very difficult to feel, and when you do find it, it's gonna feel soft and squishy and not nice and firm and contracted like it should be. Question.
Thank you.
It also may be higher than expected. Okay. And if it's related to the bladder, then it'll be higher and off to the right, kind of pushed out of the way. Okay. Even if you see the mom and she's got a lot of extra bleeding externally, it may not even be really reflective of what's going on, because if she's been laying in bed, there's a good portion, a lot of it is pooled in the uterus, and when she stands up, you'll find out, because it'll all come pouring out. If you've had a baby, do you remember them coming in and pushing on your stomach? Right, so they're feeling the fundus, and they're also pushing down to expel any clots or blood that may have pooled in the uterus, because anything that stays in there is going to affect the ability of the uterus to stay nice and contracted. So we want to have everything out. So for moms who aren't getting up and walking around, they're going to push on the belly. Push everything out. Okay, so if we have a boggy uterus or a soft uterus and not a nice and contracted one, a nice massage will remind it to contract. Okay, so it's the opposite, right? When you have a tight muscle and you massage it, that relaxes it. You want to massage a boggy uterus to contract it. Huh? It's not pleasant. I'll tell you that. It's not the worst thing, but it's, I mean, you can feel it. If it's related to the bladder, you have to empty the bladder. You can massage that uterus all you want, but if your bladder's full, it's not going to do anything. Okay? So make sure the bladder's empty and massage for a uterus that's boggy, soft and squishy. Putting the infant on the breast can help, right? Breastfeeding, that suckling, stimulates the release of oxytocin, and oxytocin is going to contract the uterus. So we can do that. Okay, we can also give medications to help contract the uterus. Methergine, prostaglandins, all of those can help keep the uterus contracted. No matter what's going on, she should be kept NPO until the bleeding is under control. We don't ever know if somebody's going to have to go into an operating room to have any procedures done, so it's always a good idea if somebody's actively bleeding to keep them NPO until we have it under control. Next cause of an early postpartum hemorrhage is a laceration. And a laceration is a tear or a break in the tissue somewhere in the birth canal. Okay, the vagina, the cervix, perineum, urethra, all of those can cause significant amounts of blood loss. Think back to chapter 4 with Chadwick's sign and Goodell's and the increased blood flow going to the perineum. All those vascular beds are very engorged, and you can lose quite a bit in the tissue. So bleeding that happens with a laceration is going to be a continuous flow of blood. Something is actively bleeding, and the blood is going to be very red. With a laceration, the problem is not in the uterus, so your uterus is going to be firm, right? Uterus is good. You have a tear in the tissue somewhere below that needs to be fixed. So they will fix this either in the delivery room or the operating room. Either way, keep her NPO just in case they need to use general anesthesia. All right, third cause of an early postpartum hemorrhage is a hematoma. And a hematoma is a bruise, right? So we have bruising or damage to the tissue somewhere in the reproductive tract. It's not, it's forming all of that blood is pooling into the bruise. You know, when you hit your head on something, or if a child hits their head on something, you feel the bump, it's getting bigger and bigger and bigger as it fills with blood, right? That's a big hematoma. So the same thing can happen in the reproductive tract. These are kind of diagnosed based on like process of elimination, right? Because the mom will not have any increase in external blood loss because everything's going into that hematoma. And it's just making that, you know, bump, like if you had a bump on your head, bigger and bigger and bigger, but nothing is coming out externally. So the uterus will be firm, no extra bleeding. Basically diagnosed because the mom will have severe pain that does not go away with ice packs, ibuprofen or pain meds, and in addition to that pain, probably some signs and symptoms of hypovolemic shock. Depending on where it is in the reproductive tract, you might see the mass, but if it's way high up, it's going to be harder to find. Okay, so those are the three reasons for early postpartum hemorrhage. So with the uterine atony, you'll have a soft, squishy uterus, lots of external bleeding. Okay, make sure the bladder is empty before you try and massage the uterus. A laceration will have a firm uterus because the problem is not coming from within the uterus, it's somewhere in the reproductive tract. Large amounts continuously flowing bright red blood. And then a hematoma, firm uterus, no external bleeding, but signs of shock and that severe unrelenting pain that nothing helps. Okay, late postpartum hemorrhage is bleeding that occurs 24 hours to 6 weeks after birth. This is usually related to retained placental fragments or subinvolution of the uterus, meaning the uterus is not shrinking back down the way it's supposed to. So nursing care, we want to teach the woman to report persistent bright red bleeding. That is a sign that something is awry. Or the return of red bleeding after it's changed to pink or white. I'm going to prepare some meds for her to help possibly contract the uterus, and also surgical intervention, especially if it's retained placental fragments, we'll have to remove that. So treatment is oxytocin, methergine, or prostaglandins. Any of those will help the uterus contract. And if you get the uterus nice and contracted, sometimes you can get rid of that extra piece of placenta that remains. Sometimes you don't. You can have to go in and do a D&C to remove it. Okay. Ultrasound can be used. Ultrasound will show if there's retained placenta in there. And again, a D&C or a D&E can be done to remove the piece of placenta. Antibiotics are always good, especially if a lot of time has gone by since delivery. We want to make sure that any infection is covered. A subinvolution is the slower than expected or failure of the uterus to return to its normal pre-pregnant condition. So back in the beginning of chapter 9, we looked at a picture of descent of the fundus, right? And how at delivery it should be at the belly button, and then it descends by 1 centimeter every day. So by 9 or 10 days, you shouldn't be able to feel it anymore. But if that process doesn't happen or it's happening slower, that's called subinvolution, and that can increase the risk for late postpartum hemorrhage. And so signs and symptoms: fundal height greater than expected, persistent lochia rubra, so persistent red bleeding, pelvic pain and heaviness, and fatigue. Treatment is to correct the subinvolution. Why is it happening? Is it happening because there was an infection, or there's retained placenta, What's the reason that the uterus is not shrinking back down? Okay, so we can give medications to firm up the uterus like methergine, antibiotics to treat any infection, and then a D&C or D&E to remove any fragments of placenta that may remain. So in nursing care, we want to teach the mom about normal changes to expect with lochia. This is where it's important for them to understand the transition from red bleeding to pink to white or clear. Okay, because if they progress to that white or clear or even pink and then all of a sudden have bright red bleeding again, they need to notify their provider. Any fever, pain, foul smelling discharge, all of those would warrant a phone call. Clots, thromboembolic disorders. Okay, venous thrombosis is a blood clot within a vein. It can be caused by spider veins, venous stasis during pregnancy, pressure behind the knees if the legs are in stirrups. Don't forget varicose veins. That's the word I was looking for. I couldn't think of the word varicose. We have increased clotting factors during pregnancy, right, to help protect the mom from a hemorrhage, but we don't have an increased ability to break down those clots. So right off the bat, just being pregnant puts you at increased risk for a blood clot. Add to it, putting the knees up in stirrups for a long period of time, or if you have a C-section, that increases the risk even more, right? Because not only have you had surgery, you're probably not ambulating right after either. Okay, there's different types of clots that can occur. SVT, not the same as the SVT that you learn about in cardiac, probably. Superficial venous thrombosis. It's just like AMA is not the same in maternity as it is everywhere else, right? AMA is usually against medical advice, but it's advanced maternal age for maternity. You could be an AMA. SVT is a saphenous vein of the lower leg characterized by hard, painful, red, warm vein that's easily seen. These usually don't necessarily require treatment depending on how big they are. The DVT will require some treatment. These can involve veins from the feet to the femoral area, characterized by pain, calf tenderness, leg edema, color changes in that extremity, sometimes a positive Holman sign as well. And then a pulmonary embolism is when one of those little clots gets trapped in the lungs, obstructs the lungs. Signs and symptoms of a pulmonary embolism. It would be respiratory, shortness of breath, coughing, chest pain. Some people say when they cough that their sputum's kind of pink tinged, pink frothy sputum because there's bleeding that can occur. All right, you want to teach the woman not to cross their legs because it impedes blood flow. Avoid pressure in the popliteal space, that space behind your knee. Early ambulation. If they're not able to ambulate, then compression socks, the Venadine boots or the anti-embolic devices for the lower extremities are helpful. Help move that, prevent that venous stasis in the lower extremities. If they are started on anticoagulant, which if they've had a C-section, sometimes they put the moms on anticoagulants anyway, just prophylactically after surgery. If it's going to be a long-term thing, they should be taught the signs and symptoms of, what can happen if you're on anticoagulant therapy, right? Bruising easily, bleeding gums. They'll probably have to have labs followed pretty regularly depending on how long they're going to be on them, like PT, PTT, INR. All of those to check clotting factors. And stress the importance of completing those blood tests and help them cope with therapy. leading cause of maternal mortality in the United States. Okay, an infection or septicemia after childbirth with a fever of 38 degrees after the first 24 hours is indicative of infection. Okay, risks include cracks in the nipples of the breast. Any break in tissue is a portal of entry for bacteria. Okay, so your laceration, episiotomy, C-section, cracked nipples from breastfeeding, that if you had, especially if you had a placenta previa, okay, and that placental site is close to the opening of the cervix, that increases the risk as well for infections postpartum. Localized infection of the perineum, vagina, or cervix can ascend to the reproductive tract, spread to the uterus, fallopian tubes, and peritoneum, causing peritonitis, which can be life-threatening. Okay, so we want to figure out those little infections and treat them before they become problems. All right, the objective is to prevent the infection from occurring. So make sure we use and teach hygienic measures. Wash your hands, perineal care, using the peri bottle, the little spray bottle, instead of, wiping and spreading bacteria back and forth. Promoting rest and nutrition. Teach and observe for signs of infection. Teach women how to correctly apply perineal pads from front to back. This, I think, is more for the nurse if you're changing the pad on a mom or any female who's laying in the bed. When you're removing, even on an elderly patient, if you're removing an old diaper, you're not taking it out and going, like sliding it up the front of them, right? You want to always do everything front to back or top to bottom so that you don't spread any. Are you laughing at front to back and top to bottom? It's just like pulling a diaper out from underneath a baby or a 98-year-old lady. Like, you don't want to, that's just asking for a UTI. Take all their medications as prescribed. Finish your antibiotics. There's like some kind of joke or meme, like if you really want to get a nurse's attention, tell them you're feeling better and you're not going to finish your antibiotics. That's one way to get them to call you back. All right, mastitis is another infection. This is an infection of the breast. Signs and symptoms include redness and heat in the breast. It's usually only one breast that's affected. Tenderness, swelling. The breast will feel very heavy. Some moms may develop an abscess, which may have some purulent drainage. They usually have symptoms just feeling like flu-like symptoms when they have mastitis. So fever, chills. Treatment is antibiotic and analgesics. They need to continue to pump or breastfeed. Leaving the milk in the breast is just going to make it worse. It's very painful, but they have to plug along. The infection is outside of the milk ducts, so the baby can have the milk. Okay, the only thing I would steer clear is if there's like an abscess anywhere near where the baby may be latching on, I wouldn't do that, but otherwise the baby can have the milk. Heat can help, massage can help. Okay. Keep the fluid intake up. Supportive bra is always helpful when the mom's engorged or anything's going on with the breast, just for extra support. This is a very fast chapter. I think, I don't know. Oh, it's 8. All right. Mood disorders. I don't want to leave you on such a sad note here. Maybe we'll wait and watch the video that goes with it next week. All right, mood is a pervasive and sustained emotion. It can affect one's view of life, We have postpartum blues, baby blues, as I mentioned a little bit ago, these are very common. Some women end up with postpartum psychosis. It's much worse. Those are moms that harm themselves or their children. I have a better slide on this. So postpartum blues, common after birth at around day 5. They last till about day 10. Moms have periods where they feel let down, but the difference is they have joy in their life. They enjoy their role as a mother. They just have moments of a little bit of tearfulness, just emotional hormone changes that have happened. It does not affect their ability to get out of bed and do what they need to do and care for themselves and their children or child. For postpartum depression, there are risk factors: inadequate social support, poor relationship with a partner, life and childcare stress, low self-esteem or unplanned pregnancy. I mentioned in chapter 9 we don't have formal screening for this in the United States, which is so pathetic, I think, in my opinion. It's not a standard practice. So nursing, family members, support system has to kind of be aware of what to look for if they're concerned that somebody might be developing postpartum depression. Signs and symptoms: enjoyment in life, disinterest in others. There's a loss of a normal give and take in relationships. Intense feelings of inadequacy, unworthiness, or guilt. Inability to cope. Loss of mental concentration. Disturbed sleep or appetite. Constant fatigue. And they don't want to respond to caring for the baby. They're kind of indifferent to the fact that the baby needs them, or their other children, if they have others. Strains the coping mechanisms of the entire family at a time when everyone's adapting to a new household member. Communication can become impaired. That only makes it worse. Okay, so be mindful of these signs and symptoms. Nursing care: refer to a multidisciplinary team. Be a sympathetic listener. Elicit feelings. Always ask, how they're doing, if there's anything you can do to help them. Again, this is going to be a lot on the support system because it's not, it's like 4 weeks after the baby's born, usually. Observe for complaints of sleeplessness or chronic fatigue. I mean, who's not when you have a newborn? Nobody's baby's sleeping all night. They're all going to be tired. Provide support. See if you can identify ways to help her meet her own needs. Referring them to support groups. All of those can be helpful. Right. Postpartum psychosis is an impaired sense of reality. It's usually underlying bipolar disorder, characterized by episodes of mania, or underlying major depression, where the mom can have delusions. This can be fatal for both mom and infant because their judgment is very poor. They have these manic episodes where they feel like the baby or everybody would be better off if nobody was here, basically. Right. So that mom, I think that mom in Massachusetts that killed her 3 kids and then jumped out the window and is now paralyzed, I think, and has that on her conscience.
So this one lasts way beyond giving birth, because
Yes.
the lady that drove into the ocean.
Yep. Yeah, or they drive off a bridge, or they, drive into a pond. I mean, all two crazy things. Okay, there's a possibility of suicide or infanticide. They definitely need counseling. They will have a heavy list of medications, all of which pass through breast milk, so she'll have to stop breastfeeding. This last slide, and then, I don't know, I guess we can, no, we'll watch the video next week. It's kind of sad. Okay. I get everything on that? Yeah. Last one is homelessness, the homeless mother and the newborn. I think when you hear the word homelessness, a lot of times people think that they live on the street, but that's not always the case, right? Sometimes you just lack a permanent residence. So maybe that you stay with friends or family and you're always going from one house to the other. You're not necessarily like without a home, you're without a permanent home. Or hotels are another place. Some of the issues that can come up is that difficulty accessing care, especially if they're having to move over in different areas or different parts of the state or even the country. Then consistency is not there with a provider. Makes follow-up difficult. You might not know where somebody has landed. So prior to discharge, make sure they have a place to go and a way to get help for themselves and their baby. We've discharged moms and babies to homeless shelters before. There's homeless shelters made for that. There's a place in Shelton that's specifically for, I think, young moms and their children. Ruth's House, I think it's called. It just opened. Nurses can facilitate referrals to outreach programs, counseling. We have case managers in the hospital for this reason. They have access to a lot of resources. If the baby's in the NICU, we have Tiny Miracles, that's helpful as well in getting parents what they need to be able to go home with their babies. But super fast chapter compared to mine. I like to have a nice long one and then we cap it off with a short one. Like chapter 6 and then 7. All right, so next week we'll watch the video. And we have a test next week? No, we don't, 2 weeks. Yeah. I don't know off the top of my head. I literally got here this morning at 9:30 and I was putzing around doing stuff